still go ahead online. And yeah, thank you for the opportunity. As Professor Fairley said, my name is Booysen, clinical psychologist and senior lecturer at Rhodes University in South Africa. And for this particular presentation, I'd want to talk about a few elements related to the treatment of post-traumatic stress disorder within a South African context, but also thinking fairly broadly about low and middle income countries, and present some of the ongoing work that's actually still taking place within a South African context by myself and some of my colleagues. And essentially share some of our progress and thoughts and ongoing questions that we have within the specific area of work. Okay. So as I said, I think to structure this presentation in three broad pillars or three broad categories, I think it would be appropriate to firstly contextualize where this work is taking place, which is South Africa, and to briefly talk about the socio-political history of South Africa, and to provide some sort of context with regards to the prevalence and the impact and the function of trauma and mental health within South African society today, and also trauma exposure and PTSD within low and middle income countries, to get an understanding of that, and move more specifically into thinking about and talking about prolonged exposure therapy, which forms part of the cognitive behavioral therapy family, if I can call it that. And it's a trauma-focused psychotherapy that's been developed to treat post-traumatic stress disorder within adolescents and also adults, which has garnered or accrued a lot of evidence to support its efficacy and effectiveness over the last 4 decades. But my specific focus with regards to prolonged exposure therapy is certainly in adding to and further developing the effectiveness of this specific intervention, but also thinking about the feasibility of it and the acceptability of it as this evidence-based treatment is being pushed and as it's being disseminated and implemented beyond the settings and the borders of where it was initially developed, which is the USA. So I think part of my work is really trying to highlight and to place those two categories of consideration of implementation around feasibility and acceptability at the same level as effectiveness. So starting this process and thinking about South Africa and where this work is taking place was quite important right in the beginning. To know that South Africa as a country, as a nation, has a history of, I think broadly speaking, has a history of violence and trauma. And violence and trauma that is attached to the socio-politics of the country, a history of colonialism, and a history within the last, if you could say, within the last century, of an apartheid system, which essentially was a different form of colonialism, just exercised and implemented in a very different way. And with that particular background, there's also evidence of attempts and efforts within the South African landscape and society across different sectors of pushing against and trying to push through the burden and the barriers of a very complicated political history. And some of the evidence can be seen during the transition from an apartheid system to a new democratic government, to a new democratic society, with the Truth and Reconciliation Commission that was held, which was really a valiant and quite ambitious attempt to start thinking about and starting to address and trying to understand really the collective trauma, the historical trauma and traumatization in its broadest sense within South Africa. Unfortunately, well, fortunately it was a start, but unfortunately it was a start that was not necessarily pulled through right until the end, or maybe not even up until the end. It's a start that was not sustained. In a sense, one can probably see the TRC as the initial phases of psychotherapy, of really just trying to get a sense of and trying to understand the complexity of an individual or group or society's burden and suffering, and the consequences of what they've had to endure and what they've had to survive. 30 decades now down the line since 1994. As I said, various attempts in terms of trying to alleviate suffering, trying to mitigate the consequences and the impact of mental health related conditions, from depression, anxiety, traumatic stress, substance abuse, you name it. So various organizations within the general South African society trying to make access to mental health care within the public health sector and within the broader general public space more accessible, from various organizations focusing on offering support and programs and interventions for traumatic stress, rape crisis centers, to Tuzela care centers, which are connected to public health facilities and hospitals, for example, when victims of sexual violence either report to a police station or to a hospital, there's a systematic process of support that's being provided. And the South African Depression and Anxiety Group, SADAG, which has been in existence for many years, has done quite significant work within this complicated space of a post-apartheid era that has still kept several social and political and economic challenges, and one in particular being mental health. So various attempts to construct and to build and to create spaces and programs where mental health in its broader sense can be understood, can be managed, and can be treated. I've added this slide as another layer to the broader South African landscape, and connected to that, thinking about psychology as a profession, psychology as a discipline within South Africa, and within the academic space as well, the intellectual space, the space where research is taking place, where knowledge needs to be produced, but also disseminated and implemented to not only have scientific and scholarly value, but also social value and social relevance. So this particular slide reflects on the history of psychology in South Africa, and closely connected to psychology, obviously mental health, and the role that psychology played within and during the apartheid system, where psychology as a discipline and also as a profession was used as a mechanism, as a vehicle to legitimize and to instill certain racial discriminatory practices within South Africa, broadly speaking. So what are the consequences of that? The consequences of that particular history attached to psychology is that at the dawn of a new South Africa, psychology as a profession and as a discipline had to deconstruct firstly, and had to figure out its own identity in terms of a discipline and a profession within a new South Africa, for psychology to be accessible and responsive and inclusive of all persons living within South Africa, and no longer only focused on, in a very specific way, on a certain group of individuals within the broader South African landscape. And I raise this because it almost has a very global, a very general impact on various aspects related to mental health within South Africa, how we think about mental health in South Africa, and how we are trying to use the resources globally and broadly within the fields of psychiatry, psychology, mental health, public health, etc., to be able to address problems and issues and difficulties that exist within South Africa and also within other countries. And part of this process is complicated because of the past identity that psychology has carried into a new South Africa. And part of this complexity has been the debates around decolonization, of having a psychology, thinking of psychology, thinking of mental health, thinking of ways and means of how to understand and address problems like trauma, problems like post-traumatic stress disorder within a South African context, which has created, at its worst, a dichotomous positioning of that we need to only think about, or that we need to rid ourselves of, dare I say, almost anything and almost everything that's associated with the West, that's associated with the past of an apartheid, of a colonial system, which essentially means adopting, to a certain extent, a good level of criticality, but at times an extreme level of criticality where one is almost in a position where you might not, and this is really just my own experience and I think my own observation, where it becomes difficult to adopt and implement certain research practices, certain research methodologies, etc., because the painful history of what psychology was still haunts and still has a role and still plays a role within contemporary South Africa. And this process, in my opinion, I think is quite crucial in terms of thinking about understanding traumatic stress, trauma exposure, post-traumatic stress disorder, and the treatment thereof. To step a bit back and to think about mental health within South Africa within the last 30 years, within the last 3 decades. Sadly, alongside some of the pockets of excellence and progress, there's also been, to a large extent, gross forms of regress and of stagnation and of difficulties. In particular, the South African Human Rights Commission had to investigate essentially the state of mental health within South Africa and published a report in 2017. But part of the big reason why this investigation came about was connected to the Life Esidimeni tragedy, which occurred in 2016. And this particular tragedy resulted in, or was due to, gross negligence, maladministration, poor governance, and to a large extent also the mechanics of political corruption, which resulted in state mental health patients being transferred and moved to so-called new facilities, different facilities of care. And these facilities were either non-existent or they did not have the necessary resources and were essentially, sorry, and were essentially never in a position to receive and to provide the necessary care for these patients who were redirected and referred to these facilities. And this unfortunately resulted in the death of these individuals, the death of more than 140 persons. And a large part of the causes of death were found to be related to malnutrition and in some instances also starvation. Again, this highlighted and was a painful moment within South Africa broadly, but also within, and I think more so within the field of mental health, that mental health still remains to be neglected. There's underinvestment in terms of finances. There's a lack of policy implementation at provincial levels and at district levels. And that an old idea of mental health is still prevailing, that the bulk of the resources are still situated at a psychiatric level, which is at a tertiary level, which is not aligned with our Mental Health Care Act and our mental health policy framework, which essentially aims to provide the bulk of our care at a community-based primary care level. and that the treatment gap, especially within rural South Africa, which is a large part of South Africa, the majority of South Africa, the treatment gap is still more than 80%, where persons living within the majority of South African society do not have access to, to mental health care. So, what is the prevalence of trauma and post-traumatic stress and exposure to trauma look like within a South African space? In the early mid 2000s, an epidemiological study was conducted, and I believe that that research was connected to the World Mental Health Surveys, which was, I believe, driven by the World Health Organization, and found that, and this was published in the mid 2000s, I think in 2009, and found that about 30% of the general adult population within South Africa suffers from a common mental disorder, and that was estimated to be 30% of the general population. And anxiety found to be the most prevalent disorder within South Africa. Trauma exposure within that same sample was more than 70% of that particular sample. That the lifetime prevalence of PTSD was estimated to be about 2.3%, which is an interesting statistic compared to the level of trauma exposure within South African society. I think it's important to highlight and to point out that this research was conducted about 20 years ago. And a lot has happened, not just within South Africa, but globally, even within the last 5 years. So the worrying or the concern is that, these statistics might not necessarily be an accurate representation of the prevalence and the impact of mental health and trauma exposure and post-traumatic stress within South African society today. But more recently, cross-sectional research that was conducted by Anne Stevenson, who's based in Boston in the USA, and had done some research with colleagues within South Africa, and using the life events checklist, which is essentially an instrument trying to ascertain the types and the levels of exposure to traumatic events within an individual's lifetime, found that more than 90% of the respondents had been exposed to or experienced at least a single traumatic event on that specific instrument, and that close to 40% of that same sample, and this sample was spread across 3 different provinces within South Africa, but close to 40% had experienced or witnessed multiple traumatic events, and the most endorsed forms of trauma types on that specific measure was physical assault, which was more than 60%, and assault with a weapon, which was about 50%. Collectively, within sub-Saharan African countries, the pooled prevalence of PTSD is estimated to be at about 22%. Looking at younger persons and specifically focusing on university students, the National Student Mental Health Survey found that within that sample of nearly 30,000 respondents, found that PTSD was estimated to be about 21% within that specific sample, with social anxiety estimated to be about 24%. And that a specific study done at a residential university within the Western Cape, and the study was published in 2013, found that the lifetime prevalence of a single trauma exposure amongst university students was as high as 90% within that specific study. Looking at children and the levels of exposure and traumatic stress within children within South Africa, Dr. Debbie Kaminer, who's an associate professor at the University of Cape Town published a study in 2013, and this community-based cross-sectional study was conducted within schools on the Cape Flats. For some of you who might not be familiar with the Cape Flats, which is in Cape Town, The Cape Flats is essentially a group of communities and neighborhoods which consist of individuals who were uh, dispossessed and displaced and removed from their original areas of living within the broader Cape Town area during the apartheid system, with a certain law, with a certain act that was brought into existence. Literally, the following day, people were informed that you're no longer legally allowed to live within a certain area of Cape Town, and this was evident throughout South Africa. Part of the consequences and the long-term historical trauma and collective trauma consequences of, again, this broader history and background of South Africa is that the Cape Flats now still, unfortunately, connected to those acts, but also connected to present day systemic issues, is that the Cape Flats is still suffering and riddled with high levels of poverty, unemployment, and significantly high levels of gangsterism. So within this specific study of about more than 600 school-going learners between the ages of 12 and 15, reported direct or indirect exposure to community violence, nearly everybody, about 98%, 99% of the sample of these children reported to have either direct or indirect exposure to community violence. Threatened or assault exposure, about 40%. Excuse me. Witnessed domestic violence, more than 70% of this particular sample. School violence, 75%, and about 8% experienced reports of sexual abuse. And again, with knowing the prevalence and the impact and the burden of mental health in general, but more specifically trauma exposure and post-traumatic stress across the lifespan, access to treatment still remains not a reality. It's not a reality. It's not a possibility for the large part of South Africans today. Trauma exposure and PTSD. The following slides takes a few steps even further back to look at trauma exposure and PTSD beyond the borders of South Africa, and more specifically thinking about low and middle income countries. The research tells us that over 2/3 of adults living within these countries experience at least one traumatic event within their lifetime. And as we know, in most cases, it does require one specific trauma to raise the possibility of the onset of mental health related difficulties, such as post-traumatic stress disorder. Only 20% of adults living within low and middle income countries have contact with a mental health specialist or a general medical provider within the last year, compared to of about just over 51% of adults living in high income countries. And only 5% of adults diagnosed with PTSD have contact with a specialist or a general medical provider and to receive adequate psychotherapy. So not just within a South African space, but broadly within low and middle income countries, the majority of the world, where, if I'm not mistaken, the majority of persons on this earth resides, that this appears to be the case in terms of trauma exposure. Some of the barriers within these settings, within these countries, three particular barriers that has to be thought about, and to be thought about in a manner in terms of how to best understand it, to resolve it, and to work around it, is the low perceived need for treatment. Close to 60% of respondents within this particular study with severe PTSD reported to have a low perceived need for treatment. That meaning that individuals don't think that they need help or believe that symptoms are not sufficiently distressing to warrant treatment. Attitudinal barriers, which is a belief that the problem will either get better by itself or on its own, and a preference to handle the problem by oneself, and at times a lack of confidence in the existing and available forms of treatment. and also social, internal forms of stigma also forms part of the existing attitudinal barriers within low and middle income countries. And as you can see, 39% of persons diagnosed with severe levels of PTSD still grapple with and directly and indirectly experience these attitudinal barriers such as stigma and don't access or make use of the opportunity to access treatment if it is available. Structural barriers such as transportation, such as having a physical primary healthcare clinic available in one's community, having the available expertise and healthcare providers within one's community is a very big and somewhat obvious barrier within low and middle income countries as well. And against that particular backdrop of the prevalence of trauma exposure, the existing barriers, there are strategies that is being researched and that is being understood in terms of how one can, irrespective of these challenges that exist, what can we still do? In a recent briefing paper by the International Society of Traumatic Stress Studies, the briefing paper found that a few strategies are currently in existence and that is receiving ongoing attention and research. The first one in particular is task shifting and task sharing, which I believe first appeared within the literature of the World Health Organization around about 2007, and really draws on the simple idea of training other specialists or non-specialists or lay persons to provide a service that cannot be accessed or cannot be provided due to limited or the unavailability of certain professionals within that particular space. And I'm sure all of you are familiar with the concept of task sharing and task shifting. One specific example which I personally view as a success story is the Friendship Bench, which was led by, and it's still receiving ongoing attention and research today, which was led by psychiatrist Dr. Dixon Shabanda in Zimbabwe, which essentially worked within rural villages, certain rural villages within Zimbabwe, and trained senior members of those villages, of those communities, and in some instances, grandmothers were trained to provide basic cognitive behavioral therapy interventions for the treatment of and for the support of persons suffering from depression. And that very innovative strategy was found to be effective, and there are published randomized controlled trials on the effectiveness of it, and a lot of research is still happening in terms of understanding how best the implementation of this particular strategy can be strengthened within that specific context. I'll come back to, and I think a large part of this presentation and the work that's happening within South Africa attaches to some of these strategies that I'll be briefly touching on now. Is that these strategies exist, but there's so much more to it. Because the concept of task sharing is so straightforward to a certain extent, it's also highly complex and highly complicated given the specific context where the research and where the implementation is going to take place. And I think that complexity at times in the past has been underestimated, but that has certainly changed as if one looks at the literature to date. So task sharing and task shifting is one specific strategy in creating access and increasing access to evidence-based interventions for the treatment of PTSD. Right next to that is cultural adaptation and cultural sensitivity and cultural awareness and cultural acknowledgement, if I can put it like that, because some of these interventions and all of these interventions, like prolonged exposure therapy, has been developed within a certain setting and within a certain cultural milieu, and within a certain context. And in order to give treatments like prolonged exposure therapy the best opportunity to do what it's been designed to do, cultural adaptation frameworks and strategies have been developed. And this is no new idea within the field of psychotherapy. I think the earliest publications and writings around culture within psychotherapy and mental health dates back to, I think, the early 1950s. But this work is still ongoing because, again, the assumption might be that one might just need to change a few words within a treatment manual. And yet we are reminded that there are layers of complexity when it comes to understanding any context within any society and how to best understand all the different variables within that context to enable not only the intervention, but also the recipient, the patient, the client, the community, the group, the organization, to give them the best opportunity to be able to engage with this specific intervention or program. The following strategy is digital interventions because, of course, we live within a digital era and a social media era where technology is really bringing about a lot of benefits, but also at the same time elements that we need to think quite carefully about and remain to be reflective of the broader social impact and benefit of technological development and advances. Within the field of psychotherapy, generally and broadly speaking, there's been a lot of work happening, specifically within the field of trauma and crisis and disaster management. Different mobile applications have been developed. And the research, systematic reviews, and meta-analyses have found that despite the plethora of research that's been done, the jury is still out, if I can put it like that, in terms of whether mobile interventions and digital interventions as a standalone treatment is the only thing that is needed. There is research looking at mobile application interventions with the assistance of counselors, and different methodologies and different designs are being explored. But the one promise and silver lining of working within a digital space is that it obviously transcends the structural and physical barriers of distance and proximity, where access to treatment becomes a lot easier, yet at the same time it also comes with certain levels of consideration. And then multi-problem approaches, or also known as transdiagnostic models, thinking about expanding and implementing and disseminating specific psychotherapies for the treatment of, let's say, depression, anxiety, or substance use, or alcohol use, or post-traumatic stress disorder. The field has also developed and has expanded to think about treatment approaches that can address multiple related challenges or difficulties. So treatment models such as the common elements treatment approach, where a lot of work has been done by researchers at Johns Hopkins University, Problem Management Plus and Group Problem Management Plus, which is the result of a lot of work that's been done by the WHO and researchers essentially across the world, and really trying to develop scalable, feasible, and applicable interventions to various settings that can be easily implemented by laypersons, by persons from specific communities. So as you can see, talking about South Africa, looking at the prevalence of exposure to trauma and post-traumatic stress disorder within South Africa and also low and middle income countries, we are still faced with and challenged by existing barriers. One of the biggest barriers being access to care and treatment. But there are also existing strategies that's being refined, that's being better understood, and that's being developed within the field of research. So moving on to a more specific focus area, which is prolonged exposure therapy. As I said in the beginning, prolonged exposure, also known as PE, is a trauma-focused psychotherapy, which forms part of cognitive behavioral therapy. And for me, as I'd still consider myself an early career researcher, coming into the field and during my PhD, really looked at the literature on traumatic stress and realized that a lot of work has been done over the last 4 decades since the inception of post-traumatic stress disorder within the nosology of psychiatry within the DSM in 1980. Since that inception, a lot of psychotherapy research has been done to understand how best to treat post-traumatic stress disorder, where today there are several empirically supported and evidence-based treatments, where prolonged exposure, I believe, has the most randomized controlled trials to support its efficacy and effectiveness for the treatment of PTSD. And several studies is obviously being conducted within the US, but within different settings within the US and within different populations within the US. Research is also being conducted within Japan, within Poland, within Israel, and also within South Africa as well. Yet, just by listing those few countries, it's easy to see that a lot of that research has not necessarily filtered down to the global south. It's not necessarily filtered down to low and middle income countries like South America and the broader African continent, etc. So a major drive for the research for myself and a few of my colleagues and graduate students has really been focused on implementing and disseminating psychotherapies, trauma-focused treatments such as prolonged exposure, but in a more contextualized manner. And that essentially means is that, yes, we want to further develop the evidence base to support its effectiveness and how it works within countries like South Africa and similar spaces. Yet at the same time, we also realize that to have evidence to support the effectiveness is one part of the job done, that more research and research also needs to happen to understand how this particular treatment can function best within and across different settings. Therefore, thinking about feasibility, thinking about acceptability has become part of the process of broadly speaking, of contextualizing trauma-focused research. And this process is ongoing because there are many questions attached to it. So this slide I bring up now, but I also bring up at the end of the presentation, because contextualizing anything requires systemic and systematic thinking, that there are many layers, many categories, many domains to any context that one has to consider. For those of you working within the field of implementation science, and broadly speaking, translational research, would be well familiar with the complexity of thinking about organizations and context and settings. But nonetheless, under the category of effectiveness, the ongoing question, at least for myself, is to continue our understanding and to build the evidence base of whether prolonged exposure can be effective within communities, within settings with high levels of ongoing adversity and conflict. A case in point is, can prolonged exposure provide improved functioning, a reduction in symptoms for individuals residing on the Cape Flats who lives within communities and who lives within community spaces where rival gangs are literally trying to literally kill one another. Yet there are people that are non-associated, that are non-affiliated to those conflicts who have to endure and are sadly on the receiving end of that particular adversity. And one can't just merely say, but oh, okay, no, they live within a space that's too volatile. Psychotherapy is not for them. If that had to be the case, then psychotherapy and these forms of interventions might not be applicable to many persons within South Africa and similar countries. Refugees and displaced persons, as the entire world is aware, there are a lot of persons fleeing for their lives and seeking places of refuge and seeking asylum within many different sectors of the world. And those individuals leaving their home countries under a heavy burden of distress, entering new spaces, and unfortunately, at times, and this is certainly the case based on some research that we've done, entering a new space, a new country, and having to face new challenges, new forms of trauma exposure and psychological distress. And another question, as I've mentioned earlier, digital interventions, whether these interventions can by itself prove to be the only strategy needed or the only form of intervention needed to improve symptoms of post-traumatic stress disorder. Within the category of acceptability, thinking of language, idioms of expression, understanding culture, which is a very tricky and fluid concept, mental health literacy, such as issues related to stigma. And some of these barriers and some of these points that I raise here, you will remember were also raised in some of the barriers that we currently understand to be quite significant within low and middle income countries. Feasibility: can a treatment like prolonged exposure be implemented within a space like South Africa, within communities within South Africa, with the resources that we have? Because unfortunately, we don't have the luxury or the option to approach. Sometimes we do, and sometimes it works, but generally, to sit back and wait and say, we'll wait for the state, we'll wait for government, we'll wait for provincial departments just to build more clinics and to employ more people, and then we can do this. That might be a bit too long. So we need to be able to work with what we have and to really try and do what we can with the research and the knowledge and the interventions that we currently have. And the big question is eventually gets to uptake, the adoption, the sustainability of these interventions within community spaces, because there's a lot of research to support that the delivery, the provision, the implementation of treatments like prolonged exposure and other trauma-focused therapies can be effectively implemented by different specialists, such as social workers, such as psychiatric nurses, such as lay counselors, such as community leaders, etc. Yet the adoption and the uptake for that particular intervention to live within that space beyond the research, that is still an area that a lot more work still needs to be done. One glimmer of hope, to a large extent, is the friendship bench that was done within Zimbabwe, which is really a beacon of hope. But it's also a level of work that has shown us that our understandings and our conventions that we have in terms of thinking about how to enter community spaces and the broader public might need to change, and I'd like to share more of that with some of the studies that we've conducted. I'm mindful of time, so I will try my best to be succinct as I talk about some of the research that's been conducted. This particular study was a pilot implementation of a very small sample within the Cape Town area that formed part of my PhD research in 2020, and it was based at an organization called the Trauma Center for Survivors of Violence and Torture in Woodstock, Cape Town. And this individual was somebody who sought treatment and care at the trauma center, and this lady lived on the Cape Flats and lived within a community, similar community that I described earlier. Lived in a community with high levels of poverty, unemployment, and gangsterism, essentially. 7 months before she sought treatment, she unfortunately witnessed the shooting, a gang-related shooting and killing of a young of a young guy within their community, the type of guy that everybody just really knew within that community space, and he was shot and killed right in front of her as she was standing by the gate. And this really affected her functioning and impacted her life in quite a significant way. So the big question for us at the Trauma Center, and the big question for my PhD is essentially in my ongoing research, is whether these existing treatments, can they still be effective? Can it still provide somebody who has to go back to settings of ongoing difficulty and ongoing adversity might be understood in many different ways. Yet there are certain community levels of trauma and violence that is quite clear, that presents and that makes us understand that it's very tough for an individual to go back to that space. And what we could see on outcomes for PTSD, depression, and anxiety, specifically for PTSD, is that she was essentially
Recording in progress.
over a 6-session period, she was able to gain strength and courage to deal with the memory related to witnessing of the tragic killing of that individual, and that she could work through the fear related to that memory and also emotions of guilt, because she felt that she should have done something, she should have helped him, and that she should have saved his life. Another study that was conducted with a small group, again, you'll realize that we are quite modest and that we're starting slowly to build this evidence, was working with a group of university students. As I mentioned earlier, levels of trauma exposure and levels of PTSD amongst university students within South Africa is quite prevalent and is quite high. Access to mental health care within university spaces are available, but also quite limited. And the added question to that is whether those spaces offer first-line treatments for specific disorders like post-traumatic stress disorder. And sad to say that that's not necessarily the case, that students accessing mental health care at university spaces don't necessarily receive evidence-based care for conditions like PTSD. Again, over a 6-session period, over a brief intervention of prolonged exposure therapy, we could see that all of the participants who completed that treatment had reduced symptoms for PTSD, and only with a slight increase for some of the for some of the participants at a 3-month follow-up. A colleague of mine conducted the first randomized controlled trial in Cape Town, South Africa, which was published in 2018. And this study essentially trained a group of psychiatric nurses to implement prolonged exposure for adolescents within school settings within Cape Town. And they wanted to compare and they wanted to know whether PE for adolescents would be more effective than supportive counseling. And supportive counseling is generally the type of psychological care and intervention that a person would receive within South Africa. And what they found within a sample of 60 participants was that the treatment outcomes and the effect sizes for PE versus supportive counseling was greater than supportive counseling. And the same outcomes were found at the 12-month follow-up after the completion of treatment. And again, 24 months since the completion of treatment, it was found that prolonged exposure still had better outcomes for those individuals who were in the PE adolescent group compared to supportive counseling. If all goes well, a 5-year follow-up study with the same participants will be published early next year or sometime during next year. An interesting study that we recently completed again in Cape Town at the Trauma Center in Woodstock, where we worked with a group of social workers who were trained in prolonged exposure therapy to implement PE at the specific organization and working with refugees residing within the Cape Town area. The study presented us with a lot of opportunities, but also a lot of complexity around implementation science, working with organizations, working with different professionals within the social and healthcare sector, And I think even more so working with refugees, because this particular sample of refugees or persons who participated in the study literally had to endure ongoing exposure to levels of xenophobia in particular, where these individuals were persecuted and essentially at risk on a daily basis for being in South Africa, for being within the Cape Town area. So some of the participants in this study could no longer come to the trauma center due to levels of risk within their setting. Some of the findings that we collected, we're still busy writing up and making sense of the intervention data. Sorry about that, I skipped a slide. But some of the qualitative findings compared to pre and post implementation working with social workers was that due to their training, due to their profession, due to their lack of experience with evidence-based interventions, was that initially there were a lot of concerns, a lot of assumptions around how this model would actually work. Yet at post-implementation, where the participants, where the social workers could actually realize that that their clients who presented with symptoms of post-traumatic stress disorder could benefit from that particular treatment. And even the clients whom we interviewed felt that they could overcome the fear of living with that particular trauma memory that maintained their symptoms of traumatic stress. A recent publication based on a pilot implementation, which was based on PE primary care, which is an abbreviated version of standard prolonged exposure, was implemented in Makanda, which is the small town where I'm based and where I work within the Eastern Cape of South Africa. And within this particular implementation study, we worked with community lay counselors and university students to implement PE primary care, which is a 4 to 8 session model of about 30 minutes. And our outcomes were looking at whether this intervention could improve symptoms on PTSD and depression. And what we found was for our PTSD outcome measured by the PCL5, that we had a large effect size for that. And for depression, we had a medium effect size for that, which I think in a very biased way is quite extraordinary, because this was implemented by non-specialist providers within a community space over a 4-session period of about 30 minutes. As you can see, based on this particular graph, a sample of 10 participants, 10 clients over a 4-session period had reduced symptoms. And the same for depression, but not at the same level as we would have hoped for, as was the case for PTSD. And that some of the providers reflected on the experience of the structure of the model, of working with a manualized treatment, that it really helped them to stay on track. It also helped them to keep their clients on track, to focus on the work that they needed to do. And that some of the clients reflected on their ability to think about the trauma that they experienced, because a huge part of the maintenance of post-traumatic stress disorder is the fear associated with the memory of the trauma, and everything and almost anything that would remind an individual of that difficulty. And clients had the experience of realizing that the trauma memory, as painful as the experience was, they were essentially living with the memory of that experience, and that one can develop the strength and the courage and the power to not be afraid of the memory. And that's essentially a huge part of what prolonged exposure therapy is really approaching and working through difficult emotions associated with a very difficult memory. Some of the lessons and challenges, and these are the last few slides that I have, based on this pilot implementation, was really grappling with limited available infrastructure within that space, where a lot of organizations were quite open and willing to assist, but literally did not have the resources or the space for us to be able to implement this. So we had to rethink our understanding of infrastructure in the same way as the friendship bench. We had to rethink and open ourselves up to implementing this particular intervention in spaces and even within organizations that don't necessarily offer mental health care. Community partners and liaisons, again, a huge interest in terms of addressing mental health care, but it also requires one to be quite careful and quite strategic to understand who of the existing organizations and partners and liaisons are actually fit for purpose in terms of initiating and enabling and getting this process actually done. The training of lay counselors, there are existing models of training that's been developed, but with each group of people that one works with, one has to, I say has to, really think about how the training is a fit for purpose within each and every group and within each and every context. And that working with lay counselors, working with task sharing, is that these individuals should not only provide the therapy or do the implementation, but they really present and come with a rich understanding and knowledge of the context and of the community. And these counselors within this particular project really functioned at different levels, not only to provide the therapy at the end of the day. One particular facilitator and barrier, but in this case was a massive barrier, was mental health literacy within this particular context, which just made us realize that an adequate assessment of the broader community, of the broader context, is so essential. And frameworks like frameworks and models within implementation science provides a good grounding and an opportunity to do that type of work. Again, as I said, I would come back to this particular slide as these are still some of the questions and some of the aims that in my mind at least forms part of contextualizing treatments like prolonged exposure for the treatment of PTSD within low and middle income countries, within South Africa, but also within the rest of the world and even within countries like the US. Thank you so much for your time. And again, apologies for going 5 minutes over the available time. Thank you so much.